Thank you. Well, welcome everyone. My name's Betsy Nicoletti, and I'm welcoming you to this session. If you have questions, please type them in the chat window and type them to organizers only. I want to tell you that we are recording this, so if you do ask a question in the chat box, we won't be identifying you, but we are recording the presentation for further play. So I wish we could go back in time to 1988, and I'm sure a lot of you who are listening would like to go back to 1988. But I worked with a general surgeon then, and he was a pretty organized guy, as surgeons can be, and he used to give me his charges on a card, one for every day of I wasn't missing any charges. And he would write down not just the diagnosis for the surgery, gallbladder disease or colorectal cancer, but also hypertension, hyperlipidemia, high BMI, diabetes. And I say to Kendall, we don't get paid any more for one diagnosis, for 4 diagnosis codes as we do for 1 diagnosis code. It doesn't matter. We get paid the same amount. And he said to me, you know, Betsy, I just want the insurance company to know just how sick this patient is. And of course, the bubble over my head was, they don't care. But that was then, and this is now. Back then, they probably didn't even read the 2nd diagnosis code on the claim form. But things are changing for us. So how physician services are paid currently, most of us are paid almost solely on fee-for-service, based on the relative value units and the fee assigned to a code. Some of you may have 1 or 2 commercial contracts which are risk adjusted, and some of you will be joining an ACO, and that changes everything in terms of payment for physician services. Because in the past, what did we do? We got paid based on the CPT code, but often it was the diagnosis code that brought a denial for us, because medical necessity is established by diagnosis coding. But I say too often, it is in the eye of the beholder. Because if my physician says, Betsy, you need this test, then I think it's medically necessary. But the real definition, or a practical one, is, will the insurance company this service for this patient at this frequency for this indication? And that's where we're going to talk about diagnosis coding. And of course, we're going to talk about ICD10. And I do feel like the coder who cried wolf. We're going to get ICD10 in 2013. No, wait, 2014. Oh, now 2015. I do think that we are going to implement on 2015, although I've lost my crystal ball, so I can't tell you that for sure. But I'm going to just say, here's my friend Jean-Luc Picard, resistance is futile. So let's talk a little bit about ICD10. ICD10 is actually 2 coding systems. It's a coding system for procedures, for surgeries, and for diagnosis codes. Now here's the good news. We, on the physician side, are not going to use any procedure codes for ICD-10. We're going to continue to use CPT codes. But all providers are going to switch to ICD-10 diagnosis codes. And it's going to be based on date of service. One caveat to this, workers' comp is not a HIPAA-covered entity and is not required to use ICD-10. So your workers' comp contractors or carriers are going to have the option to go to ICD-10. So your software, if you're doing workers' comp, is going to need the ability to use both libraries, ICD-9 and ICD-10. This is only if you're doing workers' comp. And you may have to tell it workers' comp plan A is using ICD-9 and workers' comp plan B is using ICD-10. So if you're doing workers' comp, that's going to add a little complexity here. Would anyone like to go on vacation with me on September 30th? Because claims submitted for date of service September 30th, 2015 and prior are going to use ICD-9, and claims submitted for date of service October 1st, 2015, and later are going to use ICD-10. It's not going to be by the date we submit the claim. So if you submit a claim on October 2nd for September 30th date, we're using ICD-9. If you submit a claim on October 2nd for an October 1st date, we're using ICD-10. I do think that it will make some sense, that it will be prudent for us to have cash or a line of credit on hand just in case all does not go as planned. So this is what an ICD-10 code looks like. It can be 3, 4, 5, 6, or 7 characters long. I don't know about you, but I don't think I'm going to be able to memorize very many of these. Each character has meaning, so the first 3 characters are the category, and then etiology, anatomic site, and severity, and then the extender. So that's just what the codes are going to be like. Right now in ICD-9, we have about 17 chapters and 14,000 codes. In ICD-10, we're going to have 21 chapters, and it's going to be about 70,000 codes. Now, some things are going to look the same, and I'm going to spend some time talking today about what's the same. Although every single code is changing, many of the rules that we follow for diagnosis coding stay the same. That may not be much comfort to us when we're trying to code conditions with 7 characters, but at least the rules haven't changed. It still has an index, it's very large, and then a tabular listing. There's a table of drugs and chemicals, and the headings have changed a little bit on that, although the meanings haven't changed. The descriptions have changed of the headings. And we have this new concept called underdosing. So there's an additional column in the tables of drugs and chemicals. If you prescribe a medication for a patient and they don't take enough of it, you could report that they had underdosed. I don't know if we're going to ever do that, but you could. There's a neoplasm table. It's just like the one in ICD-9 with some additional detail for location. And then we have the index to external causes. And any of you who've been watching the popular press, this is what they talk about. Bumped into a lamppost subsequent encounter, which we all think means, oh, they bumped into 2 lampposts. It's not what it means. But those are the codes that the popular press has had the most fun with. Those are the equivalent to our E codes, and from ICD-10 perspective, remain optional. So there's a section in the general guidelines in ICD-10 that says the use of these codes is payer-driven and is not mandated. Those of you who are doing injuries and trauma, if you get denied now because you're not using E codes, then you're going to need to use these greatly expanded index to external causes. If you're not using E codes now, there's a chance you won't need to use them in ICD-10 as well. You'll have to wait and see what your payers are doing. There's a supplementary classification, Z codes. Those are our current V codes, are roughly the equivalent. So they're 3 to 7 characters long, and the first digit is alphabetic. U isn't used. And there are some excludes 1 and excludes 2 notes. That's a little different than ICD-10, than ICD-9, because we only had 1 type of excludes in ICD-9. But I'll show you some examples of that today, one example. And then in the weeks to come, if you tune in for some of the other more specific webinars, you'll see more additional examples of that. So there are 3 to 7 characters. The first digit's alpha, the second's numeric, and then they could be alphabetic or numeric. They're not case sensitive, of course. Matter so much to us if we're in an EHR, because we're going to select the code from the EHR. We won't be worried about that. There's a placeholder X that I'll show you. And then some of the key functions, we have laterality, right and left in a lot of chapters. We have much greater specificity, and many conditions are going to take more than 1 code. Well, that makes sense, doesn't it? After all, if we're going from 14,000 codes to almost 70,000 codes, we're specific. What about mappings? I'm going to talk more about mappings later. CMS did develop general equivalency mappings, the GEMs, and they told us that they were using this to migrate policy from ICD-9 to ICD-10. And many of these mappings are built into our software programs. So that's going to be a help to us. Not everything is new. It starts with an alphabetic index of conditions and symptoms that we would look up. The index is big. I personally find it a little bit difficult. Maybe I need a magnifying glass. There's a tabular listing of diagnosis codes, and that's where we select our code from. And then there are general instructions in the front of the book, just as there are in ICD-9, and then there are some chapter-specific instructions. Just as in ICD-9, we don't code possible, probable, maybe, could be, might be. We code the symptoms or the abnormal test results, rather, if we don't have a confirmed diagnosis. So that hasn't changed at all between ICD-9 and ICD-10. Chronic conditions are coded as many times as the patient receives care for that condition. If that patient comes to see you 10 times for their gout, you report gout 10 times. And then let's pay a little bit of attention to the second bullet on this slide. Code all documented conditions that exist at the time of the encounter and require or affect patient care, treatment, or management. And so if we were to go back to Dr. Kendall, who put all those diagnosis codes on his card, he wasn't treating that patient's hypertension and chronic kidney disease, but it affected his treatment. He might send the patient back to primary care or to a specialist in order to get assessed for that before he did the surgery. So if your physicians are saying, 1, colorectal cancer, hypertension, go back to primary care, that's a condition that you should be reporting on your claim form. And then, of course, we don't code conditions that were previous and don't exist. In terms of symptoms, we code a symptom only when we don't have the definitive diagnosis or if it's not typically associated with that condition. So if the patient comes in with a chief complaint of pain and the physician says, you have osteoarthritis, we code only the osteoarthritis. We don't code the pain condition because that's a known symptom. But if the patient had an unusual rash that you thought might be connected with the osteoarthritis in some way, then you would code that second condition. And then there are some combination codes, and I'm going to show you those combination codes. If it's a minor problem, these are the same rules that we see in ICD-10. If it's a minor problem, we code it. And if you don't address it, consider it, or document it, then we don't code that condition. So we don't use the problem list as our assessment for the claim form. Now, if you have a risk-based contract, then you certainly want to be reporting underlying conditions annually. The guidance for history of hasn't changed at all from ICD-9 to ICD-10, but I see us doing this wrong sometimes in ICD-9. If the patient is not being treated for a cancer and has no evidence of cancer, then we switch from the cancer diagnosis to the personal history of. So it would be incorrect if a patient had had colonic polyps and they were removed 5 years ago to say the patient has colonic polyps today and use the 211.3 diagnosis. Instead, we switch to a V diagnosis, personal history of. And it's the same thing that we have in ICD-10, the same rule, only now there's Z codes. As I said, it's a whopper, so it gets bigger from ICD-9 to ICD-10. And we're only using the diagnosis codes. We're not using the procedure codes. There is a high degree of specificity. So here are just a couple of examples of that. In ICD-9, we have a bimallear fracture with 2 codes. When we get to ICD-10, there are 6 codes with 6 different 7-character extenders. So we have 36 options. One of the webinars that I'm doing for you is Injuries Are Going to Hurt, and injuries has the biggest increase in the number of codes, and they are going to be more difficult for us to code. But other parts of the book get more specific too. Gout goes from about a dozen codes to 5 different types of gout, and then which joint is it? This always makes me think head, shoulders, knees, and toes, but is it the shoulder, the elbow, the wrist, the finger, the hip, the knee, the toe? Where's the gout? We've got laterality in it. Is it that right toe or is it the left toe on the left foot? And is it with or without tophus? So it is hundreds of codes. And then ulcers go from, a dozen codes to over 125 with increased specificity for location. Is it the upper or the lower back? Laterality, is it the right or the left? And then the stage of the ulcer is built in. If you've ever sold a house, the realtor comes over and says to you, this is a great house, just terrific. And it would be worth thousands more if only within a different neighborhood. That's just what you want to hear, right? So location, location, location. There's laterality for a lot of conditions. Every code but some congenital codes, you have to differentiate, is the condition right, left, bilateral, or unspecified? Ear codes have right or left. Almost all the musculoskeletal complaints, injuries, many parts of the skin chapter, and ulcers. And then there are more locations. So is it the upper or the lower lid? It's not just the lower leg. Is it the knee, calf, ankle, foot, or digits for a lot of things? And for example, knee pain has a code for right knee pain, left knee pain, and unspecified knee. Usually we would know which knee it is. If there isn't a bilateral code, then we code, and the patient has the pain in both conditions, then we code both. Injuries are going to hurt. It's the largest increase in codes, location, specificity, laterality, and then there are a lot of with and without. Now, we have with and without in ICD-9. That's not a new concept for us, but it expands. It explodes in ICD-10, with or without foreign body, with or without penetration into the peritoneal cavity. And then we have this 7th character extender, which I'll talk about, which is going to be very difficult for fractures. And this greatly expanded what were the E codes. So let's talk about the 7th character extender. It's used in injury, obstetrics, external causes, and some other places that I'll tell you about. For most injuries, we're going to have the choice of A, D, and S. A, and when you get your ICD-10 book, so I put just a very brief description here. In your ICD-10 book, in the front of the book, in the general guidelines, are the complete descriptions of what's in A. And in A is when any physician sees the patient for the first time for that injury. So the ED doctor and the orthopedist and the primary care doctor would all use an A for the initial active care of that treatment, for the active care, not just really the initial encounter, although that's what it's mostly going to be. It doesn't correspond to new or established patient. It's for this injury. The subsequent encounter is for routine healing, and the example they give in the ICD-10 book is such as a cast change. Of course, we don't usually submit a claim for the cast change. Sometimes we do. If we're putting a new cast on, I guess we have to bill for the cast material. But often in the global period, we wouldn't even be submitting a code. But we would use that same code, the same 6-digit code that we used for the initial injury, but now on the subsequent encounter, we'd use a different 7th character extender. And then for the long-term after effect, for a sequel, we use the same initial diagnosis code and change the 7th character extender. For fracture care, though, there are more options. Was it routine healing, malunion? And for certain fractures, for certain big fractures, it's the Castillo classification as well, indicating the amount of soft tissue damage. Now, the 7th character has to be in the 7th position. What if we only have 4 or 5 digits? So we used to say X marks the spot, but now we say X holds the place, because ICD-10 has this placeholder. It holds the place for future expansion, or the 7th character and we didn't have a 6th character. So here's an example of a code, adverse effect of tetracyclines. This is where the X is a placeholder code between the 4th and the 6th character. And we would need, because it's an injury, we need, is it the initial encounter, the subsequent, or the sequel? So the complete code for this, if it were the initial encounter, would be T36.4X5A. Now, you don't have to remember that it needs an X. If you're in your book, it will tell you, and if you're selecting a code from your EMR, it won't let you select a code. It won't let you move that over and put it in a different position. So this 7th character does have different meanings in different chapters. It's the Glasgow Coma scale in the Signs and Symptoms chapter. In obstetrics, if a patient has multiple fetuses, it's the fetus number. The stage of glaucoma in the eye chapter. And for our friendly gout, it is whether it's with or without tophus for chronic gout. So that 7th character extender, we don't see it in all the chapters, and it does have different meanings. The external cause of morbidity. So these are the optional codes. They remain optional in ICD-10. But if you need them now, if you need E codes now, you're going to need these codes in ICD-10. They're detailed. And notice they get the 7th character extender. So here we have a pedal cycle passenger injured in collision with other pedal cycle in traffic accident in initial encounter. For a while I'm like, what is a pedal cycle? But of course it's a bicycle, but it could be a unicycle or a tricycle, so I guess pedal cycle is the right terminology. It's a little odd, isn't it? These external causes are really expanded. They're very specific for transport, other types of accidents, intentional self-harm, assault, and then more. If you need E codes now, someone's going to have to pay attention to these. If you're not using E codes now, if your payer doesn't require them and it doesn't slow down payment, then you don't have to worry about the external cause chapters. Mothers first, I say this of course, and that's because at the beginning of the obstetrical chapter, it says if a code from here can be assigned, code it first. That is, the patient may have come in for something else, but if the patient has a high-risk condition in pregnancy, assign that first. One of the changes in ICD-10 is that there are different codes based on the trimester of the patient. So you say, whoa, different codes for different trimesters? Oh, that's okay, because we submit it globally at the end. Well, mostly we submit OB globally at the end, but the patient may come to us at a different time in her pregnancy, may change insurances, may change doctors, or we may, some of our state Medicaid programs require that we bill visit by visit. It's going to take a little more work to do obstetrical coding in ICD-10. Combination codes. So there are a lot of combination codes in ICD-10, and this is what I'm calling the with and without. So notice the first example. It's an I. It's never a number at the start, so I've used a font that shows that that's an I and not a 1. I-83.211, varicose veins of the right lower extremity with both ulcer of the thigh and ulceration, with both ulcer and laceration. So notice if it's right lower, we could have left lower, right upper, right upper, upper and lower. We could have this varicose veins without complications or with, and there's a whole list, with pain at rest, with intermittent claudication, with ulcer and ulceration, and then there's a note to use an additional code to identify the severity of the ulcer. So the cardiac codes don't change much for heart conditions, but vascular changes a lot because of this increased specificity. All of you who are using 311 for depression as a default, think about whether the patient has major depressive disorder. And if the patient has major depressive disorder, either single or recurrent, begin to change your coding for that in ICD-9. So we'll be ready for it in ICD-10. So major depressive disorder, recurrent, so is it single episode or recurrent, without complications or with complications. And it tells you that with psychotic symptoms, and then the severity is listed as well, mild or moderate. So we're going to have more choices for detailed coding. We have GERD, K2 1.0, GERD with esophagitis. There's a code for GERD without esophagitis, and then an unspecified code. Alcohol abuse, the substance abuse coding goes up quite a bit. Alcohol abuse with alcohol-induced anxiety disorder or with other complications or without. And substance abuse is divided into, we're going to talk about that as one of our topics later, use, abuse, and dependence. And let me just say this, those are clinical terms. We coders are not going to look at the note and say, well, I think this is just plain use, or, oh, this is terrible dependence. We count on our clinicians to tell us that, and then we'll find the right codes. So there are combination codes that indicate both the diagnosis and the complication or manifestation, and for some that's the complete code, and for others it says code also or use also, and I'm going to go back a slide, just like we saw in the first varicose veins description, example. Use additional code to identify severity of ulcer. Now, if we're working out of a book, we nerdy coders are going to see that. But if you're selecting a code from your EMR, you may not see that and may not add that additional code. That's not a change really from ICD-9. I think it's the same situation that we have. But if we're coding from a book, we're going to know to go and do that. So what's the meaning of excludes? There are 2 excludes notes in ICD-10. So we just have one excludes in ICD-9. If you look up a diagnosis code, it'll say excludes, and it tells you what conditions aren't there. But exclude in ICD-10 we have 2. Excludes ones means this code isn't the code you're looking for, and they should never be assigned together. So sleep apnea and sleep apnea of the newborn should never be assigned together. So if what you're looking for is sleep apnea of the newborn, P2 8.3, don't bill G4 7.3. But excludes 2 means this isn't your code, but if the patient has both conditions, you can assign both conditions. So if the patient has insomnia and sleep apnea, or insomnia and insomnia due to a mental disorder, you can assign both codes. Really, could anybody but coders split hairs quite that much? So let me switch gears and talk a little bit about routine exams. Routine exams in ICD-10 change in a couple of ways. One, we're going to differentiate with and without abnormal findings. Second, for prenatal care, either for supervision of the normal prenatal care or for high-risk prenatal care, the code changes by trimester. I said to a group recently, well, ICD-10 won't be bad, but stop delivering babies and don't do any trauma, then it'll be fine. But of course, we have to do what we have to do. There are newborn codes that I'm going to show you, one for under 8 days and one for 8 to 28 days, and it's one code for all immunizations, not most. One diagnosis code for all immunizations. So here we have some newborn codes up to 8 days old or newborn 8 to 28 days, and that does not have a with or without abnormal finding designation. Whereas when we do routine child health, we're not just going to bill one, V20.2 code anymore. It's encounter for routine child health examination with abnormal findings or without abnormal findings. And we have those same distinctions for adult medical care or for GYN exams. So it's a busy slide, but basically we have well child, well woman care, and well adult care, and each of those is further broken down into with or without abnormal findings. Now you're going to say to me, because this is my first question, do I have to wait for the pap smear to come back to code this? And when I look at the front of the book, those general guidelines, then they tell me it's abnormal findings at the time of the visit. You don't have to wait for test results to come back or change the code to abnormal because of the test results. ICD-10 further says, code first, the examination code starting with the letter, and code second, abnormal findings. So if you did have a patient who came in and had a breast lump or an ovarian lump, you would code first the examination code, the V10 code, and code VO, excuse me, I'm saying V. It's going to be hard. The Z code, and then you'd code the abnormal findings. All right, sequencing notations. I'm only going to talk briefly about this. Many of us who are coding in our EHRs don't see any sequencing instructions. And in physician practices, we haven't paid a lot of attention to sequencing. We have put the diagnosis codes on. But there are sequencing instructions in ICD-10 just as in ICD-9. I think in practicality, we're going to do just what we've been doing now unless we really get some denials or complaints from our payers. So how about this? I'm just going to submit all unspecified codes in October. Why not? I don't have time for this. Now, if we were together, some of the physicians would raise their hands and say yes. So why might we not do this? Most diagnosis codes will support the medical necessity for an office visit. When I talk to groups of coders, I say, do you get a lot of denials for unspecified diagnosis codes? And they say, no, not for an office visit. But however, comma, if you are ordering a diagnostic test or you're performing a procedure on a patient or doing some other kind of service, something that has a payer policy, either a Medicare, national, or local coverage determination, or a private payer policy, there's where we run into denials based on our unspecified diagnosis codes, because it'll say it's not a covered indication or it's a medical necessity denial. So if I were focusing my attention in October and I didn't think I could use the full range of ICD-10 codes the first day, I would be focusing my attention at the issues that I might be getting denials on now in ICD-9 if I'm not careful, where I'm getting queries back, the lab says it won't be covered, or where I'm doing procedures or services that are covered by a payer policy, and I would pay attention to those. Now notice the last bullet here. Unspecified codes don't risk adjust. So if you're joining an ACO, or if you have any commercial payer policies, commercial contracts that vary your payment based on how sick your population of patients are, these unspecified codes won't risk adjust. So you're going to want to be changing what you do about that. If it's unspecified in ICD-9, it's really unspecified in ICD-10. And we'll talk about this when we go to mapping. But here are some examples. And this first example on the slide, this is why I don't think I'm going to be memorizing many codes. S93.409, sprain of an unspecified ligament of an unspecified ankle. Now, we might not always know what the ligament is that's sprained, but we'll certainly know the ankle. Or K27.9, peptic ulcer, site unspecified, unspecified as acute or chronic without hemorrhage or perforation. The digestive codes get pretty specific as well. Now, some of you may have changed your ICD-9 definitions in your EMR, or you're using a paper encounter form and you're using a lot of unspecified. So you might have 682.9 cellulitis, where the actual definition is cellulitis and abscess of unspecified site. So think about mapping. If you're using an unspecified code in ICD-9 and you're going to try and map it to a specific code in ICD-10, it's not going to map that way. And why did we do that? Why did we change the definitions? We did that to help our clinicians find codes, because the terms that that the clinicians use aren't the same as the terms in the ICD-9 or ICD-10 descriptions, the book. We did it because we have no predictive search in our software. But now, having that, it isn't accurate and it isn't going to map well. So that's a problem. Let me talk for a minute as I go into talking about mapping, about predictive search. So here's an example. I type in FA and Google suggests Facebook. It predicted what I was going to do based on my past behavior and my favorites, essentially. I don't have a set of favorites with Google that I know of, but they know I have them. So this would indicate I spent too much time on Facebook. And then I type in, what is predictive search? And even with a spelling error, it brings me what is predictive search. That's because it's smart, and it works with a clinical example as well. So I ask you, can our physicians, nurse practitioners, physician's assistants do this with diagnosis coding, or are they on a treadmill looking for a needle in the haystack? And what are we going to do when we have so many more codes to look at if we don't have predictive search in our software? And it's too late now. I mean, we're not changing software between now and October 1st, so either we have it or we don't have it. So one option, we're going to flag the coder. We hope it's not this, and I hear this all the time. I use any diagnosis that lets me leave the field and get on to the next patient. Or are we going to open up search in a new search box? You know, thank you, Google. As an aside here, we don't code from Google, but you might use an electronic search tool, either Google or another one that is a little bit better, and I'll tell you about that later. We might use a better, an electronic search to help us get to the right place in the book, but not to code from. We're using it as an index, essentially. So here are some critical search functions in ICD-10. It displays results after a single letter or two, just like I put in FA and it came up as Facebook. Key terms and synonyms are in use, so we don't have to know the exact wording that's in the ICD-10 book. It will find it for us. Favorites are displayed first, our own favorites and our specialty favorites, and it learns individual provider favorites. But we still have to have full access to the whole ICD-10 library when we see that case that we've never seen a condition since we went on our EMR. And these critical functions won't let our clinicians select an obsolete or incomplete code. And we do worry that ICD-10 is going to slow our clinicians down. And I wish I could say to you it's not going to, but it might. So you want to think about your schedules for the first week in October. But predictive search is going to improve accuracy, decrease our unspecified codes, and decrease our medical denials. So let's just talk a little bit about mapping. Won't it all map automatically? So I talked before about GEMS, this general equivalency mapping, but we're going from 14,000 codes to 70,000 codes. About 25% will map one-to-one, most with a change in description, but that leaves 75% that aren't going to map. Mapping may not find you the exact code, but it's going to get you to the right section of the book. But if it's unspecified in ICD-9, it's not going to get any more specific in ICD-10. Is your software mapping now? So sometimes I talk to clinicians and they say, I don't have to worry about ICD-10 because my system is already showing me the ICD-10 codes. And some of you have that. So you have your problem list, and if your problem list includes an ICD-9 code, the ICD-10 code shows. But again, when I look at those, they are really unspecified. Maybe they're going to get a claim paid for an office visit. They're not going to risk adjust, and they're going to be problematic if you're ordering a test or doing something that has a coverage policy. And why are they unspecified? Because the code was already unspecified in 9, or in ICD-9, it was as specific as it could get, but there are so many more options in ICD-10. So mapping programs are going to be a help to us if they're built into the software. They're going to decrease our search time, although some groups, when we look at their mapping, actually say, no, it's going to be better for me to just start fresh because I have a better search function in my EMR. In some instances, it should prompt you. So if we're using knee pain as an example, we hope it's going to prompt you when you select knee pain, when that patient comes in October, to use the right or the left and not just to go with the unspecified code. Now, what if you don't have any of that? You're still on paper, or your software doesn't have predictive search the way some high-priced fancy software does. Well, there is a free program online, ICD9data.com maps to ICD10data.com. And you could put this, if you could get a quick link in your software so that that was up for clinicians, so that if you had the ICD-9 code, you could do a search, do a quick link, and get to ICD-10. It's not the best, most easiest program I've ever used, to tell you the truth, but here's an advantage of it. It's free. So if you don't have an internal predictive search, you might try that. And it's pretty good, I've got to say that. It's not terrible at all. Let me just show you a few examples, and then I'm going to talk a little bit about implementation, and then we're going to open up the floor to questions. So if you have any questions, make sure that you type them in the message box to organizers only, and then we'll get those questions answered. So here's the first mapping that I want to show you, streptococcal sore throat. It has a 1-to-1 match to J02.8, streptococcal pharyngitis. So the wording has changed, but that's the exact right code. So when I talk about that 25% of codes that have a 1-to-1 mapping, some with wording change, here are 3 that do. Microcalcification on mammogram, it just gets a little bit more specific here with the description of it in ICD-10, but it's the same code. And breast mass, it 611.72, an unspecified breast mass in ICD-9 is an unspecified lump in the breast in ICD-10. Notice that this code doesn't have laterality, and please don't ask me why it doesn't have laterality, because when we look at the next description, solitary cyst of the breast, this one is the right, the left, or unspecified. And if the patient had a cyst in each breast, I think there's a code for multiple cysts in the breast, so we wouldn't use the both of these together. But there's an example where one code goes to 3, and we do have laterality. And then we have one-to-many. So cellulitis has about 10 codes in ICD-10, and it has about 40 codes in 10 codes in ICD-9, and about 40 codes in ICD-10. And remember 682.9, if you use that and you cross it without a location, it is going to be a very unspecified code. And why do we get so many in ICD-10? Because we have laterality for location and greater specificity of codes. Pressure ulcer goes from 10 to over 125. Location, laterality, and the stage of the pressure ulcer is built into the code, whereas now in ICD-9 we would put 2 codes down, one for the location and one for the stage. In ICD-10 that becomes 1 code with the greater specificity with the stage built in. And gout I already told you about. It's my favorite for why ICD-10 has gotten so big. So let me talk for a few minutes here about implementation, because we are at 4 months and counting. We've got 4 months till we implement. And the first key task is physician and staff education. And we're doing this on our webinars. Now, if you're in a multi-specialty group, this might not be enough for you. And coders might want to consider some of the complete, all 21 chapters, chapter by chapter. And, AAPC and AHEMA has those. I don't think we want to do that for our physicians. I think that's going to make our physicians very unhappy. And I've had some doctors who've those chapter by chapter, and they're really aimed at coders. But you want to think about whether these, 5 or 6 sessions that we're doing are specific enough to your practice when we're done with them. And if not, look at your specialty society and see if they have any other webinars that you might attend. And physicians, we want to train physicians as close to September as we can if we're training them on their actual software. Okay, but we don't want to be, let's not go to heck with the joke and do it on September 21st. Testing, what I hear from everyone is that they cannot test with their payers, and that their payers tell them everything's going to be okay, and their software tells them everything's going to be okay. This makes me nervous. I would prefer to hear from all of us, yes, we're able to do end-to-end testing. So if I were in a practice, I would be calling my vendors and my insurance companies and seeing if I can't do testing. And there are 2 types. One, just did you receive this packet that has ICD-10 codes in it, or were you able to process a claim with ICD-10 codes? And there's very little of that kind of testing going on as far as I can tell. If you're on a cloud-based software platform, EMR platform, then you're on the up-to-date version, because when they update it in the cloud, it updates. But if you have a server and you have that software loaded on your server, you want to make sure that you are on the final, the most recent update to that software. And if I weren't, I would try to do that sooner rather than later. That's another task I wouldn't wait till September 15th for. We all know what those updates are like and the problems that we can have with them. So update, update, update right away. When I first did the gap analysis, I said, goodness gracious, what is a gap analysis? But it's pretty simple. It's printing out a list of your top ICD-9 codes, maybe the top 50 to start, for your practice, or clinicians have very different types of practices. And then looking at the documentation that you have and trying to code in ICD-10, and then seeing what's missing. We didn't have laterality. We didn't know if it was the initial or the subsequent encounter. We didn't know the specific location of the lung cancer in the bronchus or the lung in order to a specific code. So if you, that's basically doing a gap analysis, and you do that with your first 50, and then you go ahead and do it with the rest. Look at mapping. So if you have mapping within your software, then just take a look at that and see how specific the codes are. Now, nobody has extra time between now and October 1st. I think there's some vacations that everyone is going to want to take. But if you had the capacity to update any of your problem lists for your patients with chronic diseases who you see frequently, that would be helpful. If you have templates or order sets with ICD-10, ICD-9 codes built in, you want to make sure that you're updating those now. So maybe you have a template for pharyngitis, and it has some choices in it, pharyngitis, streptococcal pharyngitis, etc., whatever those choices are. You want to update those now so that you're using, so that they're ICD-10 codes and that they're accurate, and you're not slowed down on October 1st. And sometimes in computerized order entry, if you're ordering a lipid panel, you may have a selection of ICD-9 codes that you can choose from. Then you're going to go ahead and update those order sets now. And finally, any services that you're doing that have a national or local coverage determination, coverage policy from Medicare or from private payers, you want to look at those. And that can include screening colonoscopy, mammography, wound care, minor procedures, minor skin procedures. All of those are going to be updated with covered ICD-10 codes. And so you've got to go online and find those for the services that you perform and just make sure you know what the covered services are going to be. Now today, if you haven't done it, buy an ICD-10 book. Although I think they're back-ordered on Amazon, this version anyway. Some of you may have a 2014 or 2013 version of the book. That works perfectly well because the code sets were frozen. Yay, this made us happy. The code sets were frozen, and they only added new codes if there was a new disease. So you're going to still be able to use those, but if you haven't ordered a book, order it, even though it says draft set. You can be ready. We're going to buy a book. We're going to think about whether you need any other scheduled education or if these webinars are going to work for you, and that's going to depend on your specialty, whether that's enough or not. Sigh for the third one. If we're allowed to test, we're going to test. And update your codes. And concentrate on serious conditions and on things that you code most frequently. If it's a condition that you code 3 times in a year, we're not going to worry about that in the same way as if we have a condition that we code 3 times a day. And the next quote is a quote from the 1860s, and it's about Dr. Thorne. And my apologies to women physicians, but even back in 1860, Anthony Trollope wrote this about Dr. Thorne. Perhaps in no career has a man to work harder for what he earns or to do more work without earning anything. And you know, that's pretty amazing. It was before ICD-9, relative value units, and ICD-10. So I don't know if that cheers us up or not. My contact information, and if you have any questions about today's presentations or upcoming presentations, here is the email address that you should send those questions to. Now, I've left us 5. If there are any questions, I think we're going to hear those read out loud, and I'll do my best to answer them. So now,
so we had a question about whether or not to rely on mapping or just search for ICD-10 codes in the system.
Okay. So that's a good question. And it partly depends on how specific your ICD-9 codes are. And it depends, the second thing it depends on is how good your search function is in your computer, in your EMR program. So some groups tell me that they are prompted, that their software, when they're putting in knee pain, prompts them right or left. If they're putting in knee sprain, it prompts them initial encounter, subsequent encounter, or sequel. If your software and it is prompting you, then I think I would use the search function. But if the search function is not good, then I would go back and look at mappings. And the caveat that I'm going to say about mappings is we want to make sure that we're not selecting and using forever and ever an unspecified code, because that's what mapped from ICD-9 to ICD-10. And so even if in the first week of October we can't update all of those mappings to the more specific code, someone should be thinking about those unspecified codes in ICD-10 and trying to get them updated. And just like in ICD-9, so here's one thing that's good that I'm going to mention. Codes that end in .8 are specific codes. The diagnostic statement is specific, it's just that we don't have a more specific code for it. So in both ICD-9 and ICD-10, don't worry about the codes that end in .8. Excuse me. If you have codes that end in .9, or sometimes they end in .90, look at those codes. Now sometimes that's the most specific code there is. There's no other code for you. But sometimes there would have been a more specific code you could have selected. So if I were thinking about updating problem lists or worrying about how specific my codes were going to be in ICD-10, I would start by looking at my list in ICD-9 of codes that end in .9 and .90.
Fantastic. One of the other questions we have, Betsy, is whether or not you recommend that practices purchase a book if they do have the codes for ICD-10 in their EHRs.
All right, so that's a good question. We coders are going to want a book. So I would say to my physician, please, even though they're in the EMR, we're not just going to use them there. We want to, because we want to read the general guidelines, and we want to read the C also and the manifestations. And sometimes, just because the code set is so big, I look at it online all the time, and sometimes I just flip to my book because the code set is so large. For clinicians, though, how many of your clinicians now have their ICD-9 book on their hip? Not many still do, but I would say that clinicians are going to work mostly in their EHRs. If you're still paper-based, then you're more likely to have to use the book, but I would buy at least one copy of the book for the office for the coders. So have I answered all the questions today for this session? I think I have. So I am going to sign off, and thank you all for joining in. Next week, we're going to do coding for chronic conditions. So please bring your questions with you if you have some chronic conditions you're coding for that you have questions about what to do next. And thank you very much.
Thank you, everybody, for joining us today. Again, if you have any additional questions that you come across, please feel free to email them to Holly at HealthFirst. Email right on the screen.
Good job. I used to work for her.